So Dr. Shrini will be presenting her case, false alarm choroidal granuloma event.
Slides are not moving. Slides are not moving. Causes of choroidal masses. It can be metastatic tumor, primary choroidal tumor, inflammatory condition or infectious conditions. 48-year-old female presented with sudden diminution of vision in right eye since 3 days associated with fever, loss of appetite and cough. Best corrected visual acuity in right eye was 6/18 and left eye was 6/6. Anterior segment examination in both eyes were normal. Right eye fundus examination showed yellowish white choroidal elevated lesion with ill-defined margin and subretinal fluid. Left eye fundus showed pigment alteration and PED in macular area. So, provisional diagnosis was right eye query-choroidal granuloma and left eye query-pachychoroid pigment epitheliopathy. On OCT right eye, we saw undulating RPE Brooks membrane complex, neurosensory detachment and subretinal hyperreflective material. Left eye showed PED with pachyvessel. Right eye USG showed medium to high internal reflectivity with choroidal mass. In 3 days later, patient visited us with reports. These were the reports, and the fundus we saw, there was less apparent choroidal elevation. We were shocked to see there was decrease in height of RPE elevation. FFA revealed choroidal hypofluorescence and we could see ink blot leak. So this was suggestive of typical CSC. Left eye FFA was showing pooling corresponding to PED. So, rapid reduction in 3 days points to the possibility of loculation of fluid in posterior choroid. We arrived at the final diagnosis as right eye acute central serous chorioretinopathy with loculation of fluid in posterior choroid presenting as choroidal elevation and left eye pachychoroid pigment epitheliopathy. Pulmonology opinion in view of HRCT was given and positive Mantoux test, but there was no evidence of pulmonary TB. So we suggested patient about observation and dorzolamide eye drops. After 2 weeks, patient presented with significant decrease in subretinal fluid and after 6 months, there was complete resolution of subretinal fluid with unaided visual acuity 6/6. Accumulation of fluid in the outer choroid in eyes with CSC is known. According to literature, 64 to 67% of patients with CSC can have this. But what is unique in my case is, even in eyes with loculation of fluid in outer choroid, the RP is flat with no undulation or elevation. Our case depicts that loculation of fluid in posterior choroid presenting as a choroidal elevation which lead to diagnostic dilemma. There was only one case report like this in 6 eyes of 3 patients. So the clinical implication, though the diagnosis of central serous chorioretinopathy is straightforward, it can present with atypical features. Due to advancements in OCT, loculation of fluid in posterior choroid is identified as a common finding in CSC. It can rarely present as choroidal elevation. Thorough clinical examination and multimodal imaging are required to confirm the diagnosis. Take-home message is, though loculation of fluid in posterior choroid is common in eyes with CSC, it can rarely present as choroidal elevation mimicking a choroidal mass.
There is an entity called dome-shaped maculopathy. So what is the differential? Why don't you consider as dome-shaped maculopathy?
Sir, because FFA we had done.
The dome-shaped maculopathy presents like this. Go and read and you will find it's similar. Like the only thing with dome-shaped maculopathy is it doesn't resolves like this.
Okay, within
that
3
is
days.
the difference. Yeah.
Okay.
So go and read about it.
Also, dome-shaped maculopathy will be seen in pathological myopia where the dome is itself located in the staphylomatous area. Yeah. Very excellent case. I've never seen anything like this.